Welcome. In this session, we'll take up a complex and extensive topic, electrophysiology, including electroretinography and visual evoked potential with their various subtypes, and electro-oculography. Electrophysiological tests are non-invasive objective tests of visual function. Unlike other tests of visual function such as visual acuity and visual field, which are subjective in nature, electrophysiological tests are objective tests of visual function. Electrophysiological tests assess electrophysiologic response of the visual system both qualitatively and quantitatively to various patterns of visual stimulus. Qualitatively, in the sense that the electrophysiological response can be correlated with the underlying cellular and molecular mechanisms, and quantitatively in the sense that the waveforms obtained in the electrophysiological response can be measured with respect to their amplitudes and time. Electrophysiological tests can differentiate between generalized and localized loss of function, can differentiate loss of function of different layers of retina, particularly between the photoreceptor layer and the inner nuclear layer where bipolar cells reside, can differentiate between loss of function of the rod and cone systems, can differentiate between the responses of the two cone systems, the LM system involved in red-green color vision and the S system involved in blue color vision, and electrophysiological tests can monitor progression of disease and response to their therapy, monitor response and side effects to novel interventions for retinal diseases, and monitor drug toxicities. This photograph shows a device which can perform all types of electrophysiological tests with a Gansfield bowl to produce various types of flash stimuli and a monitor to produce various types of pattern stimuli. And this device is a handheld device which can perform most types of electrophysiological tests apart from multifocal ERG, pattern ERG and pattern VEP. Clinical examination of the patient helps to determine the most appropriate electrophysiological test or tests to perform, and findings on electrophysiological tests need to be correlated with other structural diagnostic data, particularly from autofluorescence and optical coherence tomography. We'll also find that there are certain rare hereditary retinal disorders for which electrophysiological tests are pathognomonic and other retinal examinations are not required to come to those diagnoses. Also, electrophysiological tests are particularly important in symptomatic patients, particularly those complaining of night blindness and photophobia, but having otherwise unremarkable clinical and diagnostic examination findings. The International Society for Clinical Electrophysiology of Vision, or ISCEV, recommends the minimum standards for routine testing to allow comparison between laboratories. Normal responses vary with the type of the equipment, and each laboratory must establish its own age-wise normative data and ideally mention that with every ERG report. Electroretinography measures the electrical response of the retina to a visual stimulus and thus provides an objective assessment of the functional status of the retina. And three types of ERG can be performed: full-field ERG, multifocal ERG and pattern electroretinography based on the stimulus pattern. Full-field or Gansfield electroretinography objectively assesses the function of the entire retina, whereas multifocal ERG and pattern ERG objectively assesses the function of the macula. Since full-field electroretinography assesses the function of the entire retina, the response in full-field retinography is also called the mass response of the retina. By the term Gansfield, we mean a uniform unstructured illumination used to stimulate the retina. What is important is that full-field or Gansfield electroretinography cannot detect localized macular dysfunctions, and this is very important to remember. And not even light-adapted full-field electroretinography responses can detect macular dystrophy, even though macula is cone-dense, because most cones lie outside the macula. And in a patient with a clinically localized macular involvement, a normal full-field ERG excludes generalized dysfunction, which indicates a relatively better prognosis for the patient. In full-field ERG, a Gansfield bowl is used to uniformly illuminate the entire retina. This is the Gansfield bowl, and the response usually consists of an initial negative A wave followed by a positive B wave, and the amplitudes and the time to peak of both the negative A wave and the positive B wave are routinely measured. In generalized retinal dysfunctions, there is both reduced amplitude and delay in time to peak of these waves. And in dysfunctions localized to a sector of the entire retina, such as sector retinitis pigmentosa and partial retinal detachment, the amplitudes of these waves are decreased, but time to peak is not affected. And this is in contrast to localized dysfunction of the macula, which is comparatively a very small portion of the retina, in which, as we have discussed, full field ERG is normal. During ERG testing, both scotopic responses and photopic responses are recorded. The patient is first dark adapted and pupils are dilated simultaneously. Electrodes are then positioned and scotopic testing is first performed. Then the patient is light adapted, which can be done with the Gansfield bowl itself, following which photopic testing is performed. The placement of the electrodes are similar in all types of ERG, whether full field, multifocal or pattern, and 3 types of electrodes are involved. The active electrode is placed in the cornea, the bulbar conjunctiva or the skin of the lower lid and connected to the positive terminal of the equipment. The reference electrode is placed on the skin near the orbital rim and connected to the negative terminal of the equipment, and the ground electrode is attached to the mastoid, the earlobe or the forehead and connected to the ground terminal of the equipment. Response is recorded as difference of voltage between the active and the reference electrodes, and similar signals obtained from reference and ground electrodes are rejected to reduce background noise. The ICEV standard full field ERG consists of responses to 6 specific patterns of stimuli, all stimuli being white in color, varying in the adaptation state of the patient and the intensity of the stimulus. Stimuli other than ICEV standard stimuli are also used, and as we will see, some of these ICEV non-standard stimuli are required to make diagnosis of certain retinal disorders. For dark adaptation state testing, the patient needs to be in a dark environment for 20 minutes prior to testing, and for light adaptation state testing, the patient needs to be in a bright environment for 10 minutes prior to testing. The Gansfield bowl of the equipment with a background illumination of 30 candela seconds per meter square can be used both for light adaptation and for testing in the light adapted state. Intensity of the flash stimulus is measured in candela seconds per square meter, and the 3 standard ICV intensities of full field flash stimulus are a weak intensity of 0.01, a standard intensity of 3.0 and a bright intensity of 10.0 candela seconds per meter square. The maximum duration of a flash stimulus permitted in full field electroretinography is 5 milliseconds. Responses to weaker stimuli should be tested prior to responses to stronger stimuli, and intervals between these flash stimuli varies from 2 seconds for low intensity stimulus testing and 20 seconds for high intensity stimulus testing to allow the retina to recover between the flashes. The first of the 6 ICV standard testing is the dark adapted testing with the 0.01 stimulus, which is also known as rod specific stimulation, and the minimum flash interval which can be used is 2 seconds. The response consists of a B wave originating from the on bipolar cells of the rod system. As we have discussed in the session on anatomy of retina, rods do not have off bipolar cells. This testing assesses rod system function but cannot differentiate between dysfunction of rod photoreceptors and that of their bipolar cells. So in each of these graphs we will be seeing in this session, time is recorded along the x-axis in milliseconds and amplitude of the response is recorded along the y-axis in microvolts, and the type of testing will be mentioned with respect to the adaptation state of the patient and the intensity of the stimulus, and also frequency of stimulus presentation in flicker stimulation tests. This arrow represents the time when the stimulus is presented, which is recorded as 0 time along the x-axis, and this portion of the graph represents that recording of the response starts before the stimulus is presented. time to peak of each response is measured from the time of stimulation, and the definition of amplitude of each response varies. The next test is the dark adapted 3.0 intensity stimulus testing, which was previously known as mixed rod cone testing, with minimum flash interval of 10 seconds, and the response to the stimulus consists of an initial negative A wave and a positive B wave. The A wave has two peaks, either of which may be prominent, and in the response to DA 3.0 stimulation, only the first 8 milliseconds of the A wave is said to represent rod function. The next testing protocol is dark adapted testing with 10.0 intensity stimulus or a 30.0 intensity stimulus with a minimum flash interval of 20 seconds. In the response to this testing protocol, the A wave has an easily identifiable peak, and the A wave represents most of the rod photoreceptor function. The B wave represents function of the on bipolar cells of the rod system. This testing protocol can differentiate between photoreceptor and inner retinal dysfunction of the rod system. So with a reduced dark adapted 0.01 stimulus response, which indicates an abnormal rod system function, if the A wave amplitude of dark adapted 10.0 intensity stimulation or 30.0 intensity stimulation response is reduced, the dysfunction can be localized at the level of the rod photoreceptors. In a patient with a reduced DA 0.01 response, if the amplitude of the B wave is reduced but amplitude of A wave is spared, the waveform is called negative or electronegative ERG, which is an important terminology in ERG and indicates dysfunction in the inner retinal layers and not at the level of the photoreceptors. And the list of diseases in which the ERG is typically electronegative is important and includes congenital stationary night blindness, X-linked retinoschisis, diffuse unilateral subacute neuroretinitis, central retinal arterial occlusion, ischemic CRVO, melanoma-associated retinopathy, and toxicity to certain drugs including methanol. Oscillatory potentials in dark adaptation state are the small oscillations on the ascending limb of the B wave, which can be extracted by filtering from the dark adapted 3.0 or the dark adapted 10.0 stimulus. And this graph represents the filtered oscillatory potentials. They are said to arise from the amacrine cells and are reduced in retinal ischemia and congenital stationary night blindness. The next standard ICEV full field ERG stimulus is light adapted 3.0 intensity stimulus, also called the photopic single flash stimulus, which should be presented with a minimum flash interval of 0.5 seconds. And the response to it consists of an A wave representing the activity of not only the cone photoreceptors but also the off bipolar cells, and a B wave which represents the combined activity of on and off bipolar cells. The slow negative potential following the B wave in the response to light adapted 3.0 intensity stimulus is called the photopic negative response or PHNR, and it reflects ganglion cell function anterior to lamina cribrosa, and this is the only wave among the full field ERG waveforms which reflect ganglion cell function. Ganglion cell function can also be assessed by pattern ERG, but pattern ERG requires refractive correction and steady fixation, which are not required for full field ERG. The sixth and the remaining standard ICEV full field ERG stimulus is light adapted 3.0 intensity stimulus presented at a frequency of 30 Hz, and this is also called the photopic flicker stimulus. And in the graph here, these arrows represent the time points at which the stimuli are presented. Unlike the response to light adapted 3.0 intensity stimulus, the response to light adapted 3.0 intensity stimulus presented at a frequency of 30 Hz measures cone responses only and is a more sensitive measure of cone system but does not differentiate between the cells of the cone system. Rods do not respond to the stimulus because of the high temporal frequency of the stimulus as well as the light adapted state. In generalized dysfunction of the cone system, there is delay in time to peak of the waves, and in localized dysfunction of cone system, the amplitude of the waves are decreased but their time to peak remain normal, and the time to peak of each of these waves are measured from the time of the corresponding stimulus which generates the wave. Factors which may affect full-field ERG response include pupil size, age of the patient, and ERG amplitudes decrease with age. In infants, normal ERG waveforms are seen by first year of life, but before that, the ERG waveforms are smaller and simpler, and anesthetics which may be required to record ERG in infants and young children may affect ERG waveform. Media opacity and refractive errors may also affect the full-field ERG response. Each deflection in an electrophysiological response can be described by two parameters, amplitude and time to peak. In full-field ERG, A wave amplitude is measured from the baseline of the waveform to the trough of the A wave, and B wave amplitude is measured from the trough of the A wave to the peak of the B wave. Flicker ERG amplitude is measured from the trough to the peak of a typical waveform in the flicker response. Time to peak, also known as peak time or implicit time of a deflection, is measured from the time of the stimulus to the peak or trough of that deflection, except in cases of flickered ERG and oscillatory potentials. For flickered ERG, the time to peak is considered as the interval between the stimulus and the following peak which it generates. ERG abnormalities can be abnormalities of amplitude or time to peak when compared to reference normative data, and the reduction of amplitude by more than 25% is considered as significant. A reduction in amplitude with preserved time to peak is considered to be due to localized loss of function, and an increase of time to peak by 3 milliseconds is considered significant for light adapted A and B waves, and also for brighter flash dark adapted A wave. And for dark adapted B waves, an increase of time to peak by 6 milliseconds is considered significant. Delay in time to peak is considered to be due to generalized loss of function, in which reduction of the amplitude of the waveforms also occur, and delay in time to peak is best detected in the flicker response. In the dark adaptation series, as seen here in this diagram, as stimulus intensity is increased, amplitudes of both the A wave and the B wave increase. This is because rods whose function is reflected in the DA series have only on bipolar cells and do not have off bipolar cells, so the response of all on bipolar cells combine to generate the B wave. But in the light adapted series, as stimulus intensity is increased, A wave amplitude increases, but B wave amplitudes do not increase beyond a limit. This is because L and M cones have both on and off bipolar cells, and the responses of the on and off bipolar cells are temporally separated, which reduces the amplitude of the B wave. Indications for ordering full-field ERG is very important. The most common and the most important indication is a patient with unexplained symptoms but with otherwise normal clinical and diagnostic findings, such as in patients with nyctalopia, to differentiate between rod cone dystrophy, which is a progressive and potentially blinding disorder, from relatively benign congenital stationary night blindness. In patients with loss of peripheral vision, who usually also complain of nyctalopia, in patients with photophobia to detect cone dysfunction, and in patients with photopsia and shimmering, which may occur in autoimmune retinopathy, which may be paraneoplastic and which reduces ERG responses. Full-field ERG is also used to rule out generalized involvement in a patient with clinically localized macular involvement. In a patient with localized macular involvement, full-field ERG is normal, as we have described. So in a patient with clinically localized macular involvement, if the full-field ERG is also abnormal, it indicates subclinical generalized involvement, which worsens the prognosis for the patient. Full-field ERG is also used to assess children and older patients who cannot describe their symptoms, and to detect carriers of X-linked retinal dystrophies. And carriers of X-linked retinitis pigmentosa usually have normal fundus with abnormal ERG. On the other hand, carriers of choroideremia usually have an abnormal fundus appearance but with a normal ERG. ERG is characteristically electronegative in central retinal arterial occlusion, and in patients with central retinal vein occlusion, electronegative ERG or delay in the flicker response indicates significant ischemia, which worsens the prognosis for the patient. This is because retinal circulation supplies the inner portion of the retina but not the outer portion of the retina containing the photoreceptors, which is supplied by the choroidal circulation. ERG is considered a better indicator of disease activity in birdshot chorioretinopathy as compared to other clinical and diagnostic parameters, and the typical ERG response in a patient with generalized retinal inflammation is a high amplitude but delayed peak. Full-field ERG can also be used to monitor for early retinal drug toxicity such as from systemic chemotherapy, and to monitor for the onset of siderosis in an eye with an iron intraocular foreign body. We'll now discuss the full-field ERG findings in selected retinal diseases, and as we have discussed in isolated macular dystrophy, all full-field ERG responses are normal. In patients with cone dystrophy, the light-adapted responses are reduced and delayed, but the dark-adapted responses are normal. In patients with rod cone dystrophy, as exemplified by retinitis pigmentosa, all full-field ERG responses are abnormal, but the rod ERGs are more severely affected than cone ERGs. And on the other hand, in cone rod dystrophy, photopic ERG responses are more severely affected as compared to scotopic responses. Incomplete congenital stationary night blindness, response to DA 0.01 is undetectable, and response to 10.0 is profoundly electronegative with a normal A wave and markedly reduced B wave. And as we have discussed, an electronegative ERG indicates a dysfunction in the inner retinal layers sparing the photoreceptors. Response to LA 3.0 shows broadening of the trough of the A wave and reduction of the B wave with absence of oscillatory potentials. And the interpretation is that in complete CSNB there is loss of function of the on pathway of the rods as well as cones, with sparing of the off pathway of the cones. As we have discussed in the anatomy of retina, rods do not have off bipolar cells as well as ganglion cells, and transmit their responses to rod on bipolar cells and then to on and off cone bipolar cells. In incomplete CSNB, response to DA 0.01 is subnormal but detectable, and the response to DA 10.0 is markedly electronegative. Response to LA 3.0 shows a subnormal A wave and a markedly subnormal B wave, and response to photopic flicker stimulus is markedly subnormal, showing delay and a characteristic triphasic waveform. And the interpretation is that in incomplete CSMB there is involvement of both cone on and off pathways. In X-linked retinoschisis, response to DA 0.01 is severely reduced, and response to DA 10.0 is markedly electronegative. Response to LA 3.0 shows delay with marked reduction in the B wave to A wave ratio, and the response to photopic flicker stimulus also shows delay. There are three rare inherited retinal diseases, ERG findings of which are pathognomonic, and to diagnose these diseases, no other diagnostic tests are required, and these include enhanced S-cone syndrome, cone dysfunction with supranormal rod ERG responses, and bradyopsia. We'll find that to diagnose these entities, stimuli other than ISCV standard ffERG stimuli are required. In enhanced S-cone syndrome or ESCS, rods, L cones and M cones are absent, and the only photoreceptors present are S cones. So the response to DA 0.01 is undetectable, and DA 3.0 and LA 3.0 stimulus responses have similar waveforms which are simplified and delayed, and the responses to LA 3.0 and photopic flicker are delayed and subnormal, with the response to LA 3.0 showing only a small B wave at 50 milliseconds, which is the time following the stimulus at which S cones respond. And in ESCS, the amplitude of the photopic flicker response is lower than the amplitude of the A wave of the response to LA 3.0, and this is very typical of ESCS and is not found in normals or in any other diseases. Also, in enhanced S-cone syndrome, there is a markedly increased response in S-cone ERG, which is performed with a blue on orange stimulus. So the response to S-cone ERG in a normal individual is this one, with separate peaks for M and L cones and S-cone. The response in ESCS is significantly enhanced. In these graphs, the green line shows response from a normal individual and the black line shows response from the patient. And response to long duration LM cone ERG with a 200 millisecond orange on green stimulus is severely reduced as shown in this diagram, in which ESCS patients have a reduced amplitude, and in a normal individual the response is biphasic for the on and off pathways. The second entity in which ffERG is pathognomonic is cone dystrophy with supernormal rod ERG responses which have delayed and reduced light adapted responses, and in the dark adapted responses with low intensity flash such as DA0.001, the response is delayed and reduced as compared to normals, with a disproportionate increase in amplitude of the B wave. In scotopic responses with higher intensity stimulus such as DA0.01 and DA10.0, and in the dark adapted 10-0 response, the A wave has a broadened square-shaped trough with a late negative peak. In the third retinal disorder called bradyopsia, in which ERG is pathognomonic, patients take a long time to adjust to a bright environment from a dark environment, and in these patients the responses to dark adapted 0.01 and dark adapted 3.0 stimulus are normal. But the response to dark adapted 10.0 stimulus is normal only when the interstimulus interval is more than 50 seconds, but is reduced with the standard 20-second interstimulus interval used for dark adapted 10.0 stimulation. And the responses to light adapted 3.0 and photopic flickered stimulation are severely abnormal. In dark adapted 30 Hz flicker stimulation, a normal response is found for the initial 2 seconds of stimulation, but the response becomes undetectable after 10 seconds of stimulation. And in long duration amber on green LM cone stimulation, bradyopsia patient shows no detectable on and off responses, with blue on amber S cone stimulation, which normally shows an early LM cone response and a later S cone response. The response from bradyopsia patients shows severe attenuation, particularly of the LM component. After discussing full field ERG, we will now discuss multifocal electroretinography. Multifocal electroretinography and pattern electroretinography, unlike full field electroretinography, assess the central retina. Multifocal electroretinography produces a topographic ERG map showing cone system function at various locations in the central 40 to 50 degrees of the retina. And the multifocal ERG report shows both an array of individual responses from each hexagonal stimulus and a three-dimensional plot. Unlike pattern electroretinography, multifocal electroretinography can objectively determine the spatial distribution of the cone system function in the central 40 to 50 degrees of the retina, which includes the macula and the perimacular region. In contrast, pattern ERG assesses the central 15 degrees of the retina and is so more limited to the macula. The stimulus in multifocal ERG consists of multiple hexagons as seen in this photograph displayed on a monitor. The central hexagons are smaller than the peripheral hexagons, corresponding to increased density of the cones in the central region of the retina. And during stimulation, each of these hexagons can have either of two states, dark or bright. And these two states for each hexagon changes in a predetermined pseudo-random sequence called the M sequence, as seen here in this video. The M sequences are identical for each hexagon but shifted in time relative to one another, and cross-correlation of the recorded signal from the retina with the M sequence steps of a specific hexagon extracts the signal from the retinal location corresponding to the hexagon. So the waveforms displayed in multifocal ERG report are not ERG waves but are mathematically derived. Since the deflections on the displayed mfERG waveforms are extracted from the M sequence, they should not be called A wave or B wave, which refer to responses to a single stimulus. In the displayed mfERG waveforms, an initial negative deflection is seen corresponding to a wave of LA 3.0 ffERG response, reflecting activity of the cone photoreceptors and the cone of bipolar cells, followed by a positive peak corresponding to B wave of LA 3.0 ffERG response, and then a negative deflection. Multifocal ERG is indicated in patients with unexplained loss of visual acuity but with normal full-field ERG, such as in patients with macular dystrophy and cone dystrophy. More importantly, multifocal ERG is used for screening for hydroxychloroquine or chloroquine retinopathy, and this is very important to remember. In hydroxychloroquine or chloroquine retinopathy, waveforms from the central foveal hexagons are relatively spared, but waveforms from hexagons surrounding the central hexagons are subnormal. But later, central waveforms are also affected. Asian eyes may have extramacular involvement in hydroxychloroquine retinopathy, which may not be detected by multifocal ERG. Pattern electroretinography is used to assess macular cone system function like multifocal ERG, and pattern ERG can in addition assess the macular retinal ganglion cell function. Pattern ERG uses an alternating contrast stimulus consisting of a pattern reversing checkerboard as shown in this diagram, and when the pattern reverses, it appears like this to the patient. The stimulus field is 15 degrees horizontally and vertically, so much less than the multifocal ERG stimulus. The reversal rate of the pattern is 3 to 5 per second, so there is a minimum 200 millisecond interval between two successive reversals, and this allows recording PERG response to each reversal. And minimum 100 reversals should be recorded for signal averaging because the amplitude of the response of macula to this stimulus is very small. For pattern ERG, pupils are not dilated, refractive error needs to be corrected, and the patient needs to focus on the pattern. Electrode placement is the same as in full-field electroretinography, but corneal electrodes cannot be used as the patient needs to focus on the pattern. The PERG response consists of 3 deflections, the last 2 of which are consistent. The initial negative wave called N35 occurs in most individuals, 35 representing the average implicit time of this wave in normal individuals. So we note that the amplitudes of the PERG response is much smaller than full-field ERG response, and this is why more than 100 reversals are required for signal averaging. Then there is a positive deflection called P50, 30% of which is contributed by macular cone system and 70% of which is contributed by macular retinal ganglion cells. Amplitude of P50, which is measured from the trough of the N35 or in the absence of N35 from the pre-stimulus baseline, is useful as an objective index of macular function, but central retinal ganglion cell dysfunction may also reduce the P50 amplitude. So the P50 amplitude is reduced in macular dystrophy, macula involving generalized photoreceptor dystrophy, macular edema, and serous detachment of the retina. And an earlier peaking of the P50 deflection can occur due to severe retinal ganglion cell dysfunction. Finally, there is a negative component called N95 in PERG response, and this deflection is a response from the macular retinal ganglion cells. The amplitude of N95 provides a better measure of the function of the ganglion cells of the macula as compared with the amplitude of P50 wave, and the amplitude of N95 is measured from the peak of the P50 deflection to the trough of the N95 deflection. The amplitude of N95 is reduced in primary ganglion cell diseases such as dominant optic atrophy, Leber's hereditary optic neuropathy, and glaucoma. We may note here in visual evoked potential, particularly in pattern reversal visual evoked potential, ganglion cell function can also be assessed. But in visual evoked potential, increased implicit time is more important than the amplitude of the deflection, whereas in pattern ERG, the amplitude of the deflection is taken into account. So pattern ERG assesses the function of macular cone system and the retinal ganglion cells of the macula. In clinical practice, pattern ERG is best combined with full field ERG. In macular dystrophy, the P50 amplitude in PRG is abnormal, but full field ERG will be normal. In macular sparing generalized retinal dystrophies, P50 amplitude of PERG will be normal, but full field ERG amplitudes will be abnormal. And in maculae involving generalized retinal dystrophies, both P50 amplitude of PERG and ffERG amplitudes will be abnormal. PERG is also indicated in patients with abnormal VEP responses, in whom PERG helps in differentiating between macular retinal and macular ganglion cell dysfunctions. In patients with macular retinal dysfunction, the P50 amplitude will be decreased, but the N95 amplitude will remain normal. And in patients with macular ganglion cell dysfunction, the amplitude of N95 deflection will be decreased, and in severe dysfunction of macular ganglion cells, the time to peak of P50 deflection will also be shortened. And in only very severe dysfunction of the macular ganglion cell, the P50 amplitude will be decreased, but otherwise P50 amplitude remains normal in macular ganglion cell dysfunction. Electro-oculography assesses the health of the retinal pigment epithelium and its interaction with photoreceptors. Electro-oculography measures the corneoretinal standing potential of the entire eye, which is positive at the cornea, both during dark adaptation and light adaptation. The standing potential is the difference of potential between the front and the back of the eye and is an indirect measure of the transepithelial potential across the retinal pigment epithelium. The main indication of electro-oculography is to assess patients with suspected or diagnosed Best's disease, where EOG findings are abnormal but ERG findings are normal. Other than Best disease and related disorders, most generalized retinal dystrophies and degenerations will have abnormalities in both electroretinography and electro-oculography, and this is very important to remember. For electro-oculography, the pupils have to be dilated and the recording electrodes are placed on the lateral and the medial canthi of each eye, and the potential difference between these two electrodes are recorded. A ground electrode is placed on the forehead, and the patient is asked to make 30-degree lateral movement of the eyes by fixating on two dim red lights 15 degrees on either side, which alternately light up once every second for 10 seconds every minute. And this is continued during 15 minutes of dark adaptation, followed by 12 minutes of light adaptation. The response in electro-oculography is a series of square waves, and when the eyes move towards the positive electrodes, a positive deflection occurs, and when the eyes move towards the negative electrodes, a negative deflection occurs. During dark adaptation, the amplitudes of the positive deflections decrease to a minimum within 12 minutes, called the dark graph, and during light adaptation, the amplitudes of the positive deflections increase to a maximum, called a light peak, within 8 minutes, and the result is reported as a ratio of the amplitude of the light peak and the amplitude of the dark graph, and this ratio is expressed as a percentage, called the Arden ratio or the Arden index. Normal Arden ratio is at least 170% and requires a normal retinal pigment epithelium and normal photoreceptors with a healthy interaction between them. So in most generalized rod dysfunction, there is both a severely reduced EOG light rise as well as a severely affected response to dark adapted full field ERG. So any discrepancy between the extent of reduction in EOG light rise and the extent of reduction in the response to dark adapted full field ERG response, with the dark adapted ERG being spared while the EOG light rise is severely reduced, points towards a primary retinal pigment epithelium dysfunction. Electro-oculography is indicated when ERG is found to be not significantly abnormal, and the patient is suspected to have certain specific diseases such as Best disease, which is an autosomal dominant mutation in BAST1 gene. In Best disease, the light peak on EOG is severely reduced, but full field ERG is normal. In autosomal recessive Best retinopathy or ARB, which also occurs due to a mutation in BAST1 gene, The light peak on EOG is severely reduced, but the ERG is also abnormal and is not completely normal like Best's disease. But the abnormality in ERG does not correspond to the severity of EOG abnormality. But ARB carriers have a normal electro-oculography response. In adult foveal vitally formed dystrophy, which also occurs due to a mutation in BEST1 gene, the electro-oculography is only mildly subnormal. And the most important application of EOG is to differentiate between Best disease and autosomal recessive Best retinopathy, in which EOG responses are abnormal, and adult foveal vitally formed dystrophy, in which EOG is only mildly subnormal. Visual evoked response, or VEP, is also known as visual evoked cortical potential, or VECP, or visual evoked response, or VER. VEP measures the electrical response of the brain to visual stimulus, and since most of the visual cortex is dedicated to central vision, VEP provides an estimate of central visual function. The entire visual system from photoreceptors to cortex has to be intact to generate a normal response on visual evoked potential testing. So retinal disorders need to be excluded with an ERG in a patient with abnormal VEP response. For VEP, pupils are not required to be dilated, and active electrodes are positioned over the occipital cortex just superior to the inion, both on the midline as well as lateral to the midline but at the same level. The reference electrode is positioned superior to the forehead in the midline, and the ground electrode can be positioned over the mastoid, earlobe, forehead, or at the vertex in the midline. Response to a visual stimulus is recorded as the difference in potential between the active and reference electrodes, and averaging of responses to multiple stimuli helps in filtering VEP from background electroencephalographic signals. VEP stimulus are of two types. One is the white flash stimulus, stimulating at least 20 degrees of the central retina, and the other is a black and white checkerboard pattern, stimulating at least 15 degrees of the central retina. And the pattern stimulus can be presented in two ways, either as pattern reversal or pattern onset offset. In flash stimulus VEP, the stimulus illuminates at least the central 20 degrees of the visual field, and each stimulus is presented for less than 4 milliseconds and repeats at a rate of 1 Hz. And the response to flash stimulus VEP is more variable between individuals as compared to responses to pattern VEPs, which are more consistent between individuals. But the response to flash stimulus VEP is similar between the two eyes of the same individual and can be used to compare between the two eyes or two hemifields of the same individual. The waveforms in flash stimulus VEP response have a series of negative and positive waves from 30 milliseconds to 300 milliseconds, numerically labeled as N1, P1, N2, P2, N3 and P3. The most consistent among them are N2 and P2, the N2 occurring at 90 milliseconds normally and the P2 occurring at 120 milliseconds normally. Flash stimulus VEP is useful for patients with poor media and or poor vision and in non-verbal children with symptoms of the visual system such as decreased visual acuity, nystagmus, or roving eye movements. Consistently abnormal flash stimulus VEP responses indicate gross abnormality of the afferent visual pathway. In pattern reversal VEP, the squares in the checkerboard stimulus alternate between black and white at a reversal rate of 2 per second, and so to the patient it appears like this. The response shows waveforms with consistent time to peak across the population, but the amplitude varies between individuals. The normal pattern reversal VEP waveform consists of a dip at 75 milliseconds called N75, a peak at 100 milliseconds called P100, and a dip at 135 milliseconds called N135. And the P100 waveform is considered for evaluation, both its time to peak and its amplitude from the trough of the N75 wave. A normal pattern reversal VEP indicates an intact afferent visual pathway, and as we have mentioned, pattern reversal stimulus is the preferred stimulus for VEP in most situations. The stimulus in pattern onset offset VEP is a checkerboard which appears from a gray background and then disappears into the gray background at a rate of 1.67 Hz. So the stimulus in pattern onset offset VEP appears like this to the patient. The waveforms of pattern onset offset VEP are less consistent between individuals than those in pattern reversal VEP. And the waveform of pattern onset offset VEP consists of three deflections: a positive peak at 75 milliseconds called C1, a negative peak at 125 milliseconds called C2, and a positive peak at 150 milliseconds called C3. Applications of pattern onset offset VEP include situations where fixation is less than adequate, such as in detection of malingering and in patients with nystagmus. Pattern onset offset VEP is more effective in detecting chiasmal misrouting of optic nerve fibers in albinism, and several contrast and check sizes of the pattern can be used to assess visual resolution as a surrogate for visual acuity in non-responsive patients. Most important indication of VEP is optic neuritis, which characteristically shows a delay in time to peak, which is very important to remember. And this delay in time to peak persists even after symptomatic resolution of the disease. VEP is most commonly used to assess severity of optic nerve involvement in optic neuritis and can also be used to detect subclinical optic nerve involvement in patients suspected of having multiple sclerosis. But most optic neuropathies also show delay in time to peak. So VEP itself cannot distinguish between optic neuritis and most other optic neuropathies. On the other hand, eyes with non-arthritic ischemic optic neuropathy have reduced amplitude VEP response, and VEP is also indicated in preverbal children with symptoms of loss of vision, nystagmus, and roving eye movements. VEP is very important in detecting non-organic vision loss and malingering, and in this situation, electrophysiology is most useful to confirm diagnosis, and this is important to remember. In non-organic vision loss, VEP shows a normal response, but patient cooperation is required, particularly for pattern reversal stimulus. To recap the salient points, electrophysiological tests provide non-invasive means to objectively assess function of various parts of the visual system. They use various types of visual stimuli to elicit response from the visual system. Testing with ISCV standard stimuli enables comparison of responses obtained from different clinical centers. Non-ICV stimuli are also required to diagnose certain retinal disorders. Electrophysiological tests can differentiate between disorders which are generalized and localized, between disorders of various layers of the retina, between disorders of rods and cones, and between disorders of different types of cones. It can also monitor for progression of disease and response to its therapy. Electroretinography or ERG assesses the response of the retina to a visual stimulus. ERG is of three types: full field ERG, multifocal ERG, and pattern ERG. Full field ERG uses a white light flash stimulus of various intensities to stimulate the entire retina, with the patient first in a dark adapted state and then in a light adapted state. The response to a single flash stimulus consists of an initial negative A wave whose amplitude is measured from the baseline, followed by a positive B wave whose amplitude is measured from the trough of the A wave. Time to peak is measured from the time of the stimulus. Amplitudes of the waves are decreased in localized loss of function, but time to peak remain normal. On the other hand, delay or increase in time to peak, along with a decrease in amplitude of the waveforms, occur in generalized loss of function. The 6 ICV standard ffERG stimuli are DA 0.01, which measures the rod system but cannot differentiate between photoreceptors and bipolar cells; DA 3.0, DA 10.0, whose A wave represents rod function and B wave represents on bipolar cells, and is used to differentiate between photoreceptor and inner nuclear layer dysfunctions of the rod system; DA oscillatory potentials, which represent function of amacrine cells; LA 3.0, which consists of an A wave, a B wave, and a late negative wave called photopic negative response, with this photopic negative response representing ganglion cell function. And the LA 3.0 30Hz stimulus, also called the photopic flicker stimulus, which is more sensitive and specific for the cone system as compared to the LA 3.0 stimulus. Indications for ffERG include symptomatic patients complaining of nyctalopia and photophobia with otherwise unremarkable clinical and diagnostic findings, to detect generalized involvement in patients with clinically localized macular involvement, to detect carrier status in X-linked disorders, to detect ischemia in CRVO, to detect drug toxicity early on, and to detect onset of siderosis in patients with iron intraocular foreign bodies. Electrophysiological tests should always be interpreted in a clinical context, but there are three rare inherited retinal disorders in which full-field ERG is pathognomonic and no other diagnostic tests are required to make the diagnosis. Multifocal Electroretinography or mfERG assesses the spatial distribution of cone system function within the central 40 to 50 degrees of the retina. It is particularly used to evaluate for hydroxychloroquine toxicity. Pattern electroretinography assesses the cone system as well as the retinal ganglion cells in the central 15 degrees. It does not demonstrate spatial distribution of function within this area, but it is less prone to errors due to unstable fixation. It is combined with full-field ERG to differentiate between localized and generalized dysfunction of the retina. In patients with abnormal VEP, it helps in differentiating between macular retinal and optic nerve dysfunctions. Electro-oculography measures the standing potential of the eye, which is an indirect measure of the transepithelial potential across the retinal pigment epithelium, first during dark adaptation and then during light adaptation. Normally, the standing potential increases with light adaptation. The ratio expressed as a percentage of the peak of the standing potential during light adaptation to the trough of the standing potential during dark adaptation is called the Arden ratio, which is normally more than 170%. Normal response on electro-oculography requires healthy photoreceptors interacting normally with a healthy retinal pigment epithelium. In most retinal dystrophies, both ERG and EOG are abnormal, but in Best disease, EOG is severely affected with a normal ERG. In autosomal recessive Best retinopathy, EOG is severely reduced but only with a milder abnormality of the ERG. EOG is indicated when ERG is normal and Best retinopathies are suspected, and to differentiate adult foveal vitally formed dystrophy where EOG is only mildly affected from Best disease and autosomal recessive Best retinopathy. Visual evoked potential measures the response of the visual cortex to a visual stimulus. Normal response requires an intact visual system from the photoreceptors to the visual cortex. In a patient with an abnormal VEP, retinal disorders can be excluded with an ERG, and if ERG is normal, abnormal VEP indicates either optic nerve or cortical dysfunction. VEP can be done with three types of stimuli: flash, pattern reversal, and pattern onset offset. Most commonly, pattern reversal stimulus is used, which has a more consistent waveform across population. Flash VEP is used in patients with poor vision and or poor fixation, hazy media, and in nonverbal patients. Pattern onset offset stimulus can be used with less than normal fixation to detect malingering and to evaluate nystagmus patients, and to detect chiasmal misrouting in patients with albinism. Most common indication of VEP is to detect and monitor optic neuritis, which shows a delay in time to peak. Delay in time to peak is also found in other optic neuropathies. Patients with non-arthritic ischemic optic neuropathy usually have a reduced peak amplitude. Another common indication of VEP is to diagnose non-organic visual dysfunction, including malingering, and VEP is also indicated to detect functional status of the visual system in a non-verbal patient. It has been a long session, and thank you for listening.